Welcome to the Behavior Speak podcast. Now, here's your host, Ben Ryman.
Cool.
And,
Got it. And then
just
we are recording.
One question. I was just looking at your slides and I noticed you have, do you go by your maiden name and your married name at the same time, or what do you want to be? Who do you want to be today?
Right. I have always wanted to go by my maiden name and my married name. So Intarachote Van Etten, it's a mouthful. So I have gone to just Van Etten, but I think just like
I can pronounce that. That's an easy one.
Okay.
Yeah.
Yeah. Although I'm going to talk about that in growing up and all my nicknames.
Totally. Awesome. So I'm going to count to 3 and clap. And that's just going to be a signal that for aligning the vocal tracks. And then I'm going to do a brief land acknowledgement. And then we'll get right to her. And do you know what I mean by that?
Sounds good.
Good. Perfect.
The land acknowledgement?
Yeah. Do you guys do those down in the US of A? I think it seems to be a Canadian thing right now, but I think it's starting to catch on. Anyway, it'll be clear enough in a moment.
I'm excited.
Yeah. All right, here we go. 1, 2, 3.
All right.
Welcome to another episode of the Behavior Speak podcast. As always, I'm your host, Ben Ryman. Today on the podcast, we have Dr. Nissa Intarachote Van Etten. Welcome to the show, Nissa.
Thank you. And you got my maiden name right.
Bam.
I love it.
I just want to start by just quickly acknowledging that I am producing and hosting this podcast on the stolen lands of the Tla'amin, Kalehus, Comox, and Homoko First Nations, who were one community, one nation before we settlers came and separated them off into reserves. I live precisely in the village of Isam on the island of Sayayin, known by the colonizers as Gillies Bay on Texada Island here in northwest British Columbia. And yeah, just grateful to be here on the lands and to continue my learning journey. Today's topic is, as the title will give away, is all about culturally responsive care. Folks have probably started to see a theme in a lot of the podcasts I've been doing around culture and kind of other sort of DEI related topics because this is an area I've been wanting to learn a lot about, and what better way than to go to the experts and hear different experiences and learn about them. Before we get into that, maybe you can just tell us this kind of how you got into the field of ABA, like your origin story of sorts, and what eventually kind of led you to make this your not only a topic you've been presenting on quite a bit, but also the topic of your dissertation.
Yeah, those are great questions. I love talking about my origin. I think we all do, getting into behavior analysis and kind of what brought us to where we are today. So I got into the field in undergrad. I was a nanny in Southern California through undergrad at University of California, Irvine. And so I knew at a young age, I loved working with kids. So I was a nanny in an area that, I went in after school, in between classes, and I helped take care of kids, drive them around, drive them to their sports. And while I loved children, I didn't feel like it was fulfilling. It wasn't driving me. At the time, I was also a psychology major as an undergrad, and there were different opportunities that popped up through UC Irvine. Back then it was Craigslist, and then also the paper. That's how you found your jobs. And there are a couple ads to work with children with autism. I didn't know what that was at all. This was in the year 2000, but I knew that I was interested. Let me see what that is. Let me go and apply. So I interviewed with a family with 2 little boys on the spectrum in their home in Orange County. And I fell in love with not only the 2 little boys, but the work that we were doing. I was hired on by the family at the time. So I was what they called their tutor. And they had, it wasn't a BCBA overseeing the case, but just a master's level individual who understood special education and programming and skill acquisition, who kind of drove targets for me to provide in the home setting and then the community. So I started way back when, as a tutor in the home. I had multiple different families during summer when we weren't in school, working with families all around Orange County, driving kids, to the beach, working on going to Disneyland and waiting in line, going to the mall and maintaining appropriate behavior kind of as you're waiting for your French fries. I knew from those two little boys and that experience that I really wanted to pursue something in this field. And I learned through that work that it was called applied behavior analysis. So I applied to the Chicago school at the time and was accepted into their first cohort of at their brick and mortar in Chicago. But I loved those little boys so much, I deferred my acceptance 1 year and stayed an additional year after graduating. So I worked with them 40 hours a week.
Nice.
So 20 hours with the older boy and then 20 hours with the younger. Spent a lot of time, just learning that, and you'll see that a lot in the theme of my dissertation and then the work that I do today, that working with families is very important in making sure that families are invested in the services that we provide, that they understand the goals and objectives that we're implementing, and truly they understand ABA as a lifestyle and not just a treatment of someone coming in for a few hours here and there. Left that family, went on to graduate school, worked in Chicago and Chicagoland area, and worked again in home with another family that hired me under the supervision of Steve Ward and Terry Grimes. Steve Ward, I think a lot of people know him. He does a number of podcasts. Really enjoyed my time, learned so much from them as my supervisors, and then got the opportunity to move to California to work with Dr. Partington at his clinic, Behavior Analysts, Inc. So I went there in... Gosh, I'm trying to remember. I think this is 2005. Worked there in the clinic back then. That's when, right before insurance reform was starting to kind of move through. So then I was more of a consultant in the schools and then also working in the clinic space with families. Services back then, again, were families that either could afford services. So, right, we have an access to services situation in the early 2000s. And then we've got families who are also, they have access to funding where they're fighting school districts to receive funding to pay for treatment. So that was kind of how I started as a newly certified BCBA. And then insurance reform came through. I knew I needed to leave Dr. Partington and really understand what that meant, what it was working in a 3-tiered model, working in an organization where we build insurance for services, and then have worked at 5 different organizations since then. And now I'm at Central Reach, and I'm the manager of assessment and clinical training. So a lot of my role is training clinicians and educators on how to use assessments to make decisions, specifically the ABLLS and the AFLS. We've got some exciting work coming out of there as well.
Nice. Right on. And you also have you also are one of 3 hosts on a podcast there, if I'm correct. Yeah. And
you are correct. Yes, I'm on the Behavioral View.
The Behavioral View. Right. That's fun. And you recently, and I think I saw a post recently that you had Dr. Partington on there. So that must have been a cool sort of catch-up interview.
Yes, it's fun. We had him on to, talk about his best practice recommendations for collaborating with parents, what he's done over the course of his career, and then his recommendations, very much like the theme here in terms of compassion and understanding family differences, what brings a family to services and how we provide it in a very individualized manner to that family, their culture, their cultural constellation, and what their needs are.
Nice. And I actually just had Dr. Mueller on the podcast. And so he talked a little bit about the AFLS. We were mostly talking about the IBAO, but he told me a little bit about his sort of origins with the AFLS and kind of how that informed some of the work he's doing now. So really cool.
Awesome.
So what led you to kind of focus on both compassionate care and kind of culturally responsive care in your dissertation? Why'd you choose that direction?
That is a great question. So in my dissertation, I did dedicate it to my grandmother, Kulia Dechapan. I know we talked about this just a little bit ago, but she was a nurse, and she was a nurse in Southern California, immigrated from Thailand after kind of studying nursing. And one of the things I learned from her, and one of the things I've learned in my studies through, understanding what nurses learn in their studies, is that idea of compassionate care, right? And we know this from the paper that Dr. Bridget Taylor and colleagues wrote in 2019, that compassionate care is something that anyone working in human services, working to help others, we have to understand, we have to conceptualize in a way that it's tangible, that we can identify what are those behaviors that demonstrate compassion. And I think our field as behavior analysis, we're grappling with it for many reasons. One, we don't learn about emotions in our coursework, right? We don't learn how to manage them, how to identify them, how to respond to them. And our patients, our clients and their families, they're experiencing so many emotions. So what led me down this path was, one, I think it was my origin in working for families directly early on. So I wasn't, working for a funding source such as insurance or school. I truly was working for the family, watching them understand what their child could and could not do, right? What level of independence their child might accomplish over time, and watching those emotions kind of play out over the course of the years working in their homes. And then two, knowing my grandmother's career in nursing and her compassion for her patients really drove me to try and identify how can we bring, what Dr. Taylor and colleagues first wrote about in their paper into our field in a tangible way. And then I brought in the cultural piece just because my own experience growing up in Southern California as a Thai American really shaped how I view all of the different families that I get to interface with, all of the different cultures that I've been exposed to and had to work with. And I thought, there's got to be a way to really teach practicing behavior analysts how to approach families with compassion, and then also knowing that we have to understand their culture when they come into our care.
Yeah. You brought up an interesting point that, we don't talk about emotions in our training. And I know a lot of, so-called kind of radical behaviorists, they apply that mentalism term to this, and that that basically the happy, sad, hurt, angry, whatever, those are mentalistic terms, and as behavior analysts we can't observe the feeling of sadness or the feeling of happiness or the feeling of joy. We can observe certain behaviors folks engage in when they're happy or sad, and more recently, certainly with the rise in popularity of ACT in for behavior analysts, there seems to be more appetite to talk about emotions and sort of the verbal behavior associated with emotions, and kind of recognize that. I know you don't really know we don't really know the answer, but do you think that's a big reason why compassionate care? Because I think a lot of people wonder, as a helping profession that we're in, it's quite bizarre that it took till 2019 for us to decide that compassionate care was something we needed to do.
Important. Agreed.
And I think we've had a lot of practitioners that probably have been compassionate. I don't think we're all sort of,
exactly
feelingless sort of folks. And a lot of people use sort of compassion. I mean, they wouldn't get the buy-in. They wouldn't have, the trusting relationships with those families if they weren't being compassionate.
Absolutely.
But we just haven't really been talking about it. And do you think mentalism is sort of maybe part of the reason why that we kind of have avoided kind of going there?
Yeah, I think, if we go back to our training and our coursework in our master's, there is the discussion of internal events that we can't measure them. However, they do exist and they can account for the behaviors that we engage in. But I personally, at least from my experience, I think compassion is coming about, one, because there are papers coming out in terms of discussing what compassionate behavior analysis looks like. Rohr wrote about this, I think in 2021, Rohr and colleagues, calling it soft skills, right? Behavior analysis finding its heart. One, I think we've always all had a heart. We work with very difficult clients across different settings and very difficult cases. But I think that as we've moved into the medical model, and I know that's another source of debate in some circles, but as we're moving towards insurance-funded services, and we are aligning, I call this in my dissertation, the allied health professions, so nursing and social workers and doctors, that medical model means that we are being compared to other health professions who have training in compassionate care. So turning to our counterparts in those fields, understanding that they receive training in, they call it interpersonal relationships, soft skills, therapeutic relationships. When I did my lit review, I had to kind of look into allied health professions and find the 5 or 6 synonyms with compassionate care, because compassionate care isn't also what they call it in those fields, but it is an area of focus. So I think this is coming about, one, with the notion that a majority of our field is working in a quote unquote medical model, right? We're being funded for our services through large payers and insurance organizations. So we are starting to move towards, we have CPT codes that we're billing. We're a medical service. We have medical treatment recommendations for our clients. So in moving in that direction, there is now this notion of, we have to provide care that's compassionate, or, we've got a term for it now. But like you're saying, our colleagues, BCBAs that have been in the field for decades, they're compassionate. They can build rapport. They didn't have a name to it. It was a part of their practice. And I used to say way back when I started, way before I was in working in autism insurance reform, so right, autism funded services with insurance, we had to sell ourselves for a family to say, you know what, I'm going to hire you as a consultant. I will pay you out of my pocket. You have to prove that you have a skill, right, and expertise in your area, and that we're going to be working on really socially important targets with my child. So we were selling ourselves. So we had to build rapport and really ensure that we were, having that therapeutic alliance with families. It's a different service model now. So I think having a name for it, with that increase in behavior analysts, the increase in certificates and individuals working in this space, having a name for it does help, so that we at least are aware of what we're looking for.
That's interesting. I never even sort of considered, this whole medical model thing as being a reason to be compassionate. That insurance paying for services is a reason to be compassionate. Obviously it's not the main reason.
And I agree. No, exactly. I wouldn't say it's the reason that we have to be compassionate. I would say it's more of, when you think about when you go to see your nurse or your dentist, right? It's bedside manner. You're going to go back to that nurse or that dentist. And I have an example with my own daughter, where if that bedside manner is one that you immediately trust them and you value their how they're handling you or your children, you're going to go back. And that's very similar to what we're providing as a service now.
Only reason I mention it is because the sort of the CPTs and all these other things that I'll never understand only apply in the US, right? I'm in Canada, and
you're right.
We don't have an insurance mandate here, and in fact, and if we look at sort of a lot of the countries around the world that are now, some of them just really starting sort of their behavioral analysis in their nations, none of that exists, and they're all sort of in the got to sell myself, only people that can pay, and all those sorts of things you kind of mentioned, and so again, they have to be that as well. I also think that and it makes sense that we're going to be talking about sort of culture a lot today, that the onset of a lot of discussions. I know the Taylor paper was in 2019, but sort of post George Floyd in 2020, there's been, a massive increase in conversation,
a lot more
about both, culture in terms of sort of, well, I know culture is across the board as far as communities, but sort of culture in the way of sort of ethnicity and language and whatnot, but then also neurodiversity, and that sort of culture piece too, have all really been getting a lot more play and a lot more papers and a lot more discussion. And so, I presume, compassionate care, it's really important to consider, all of those pieces. And so I think it is timely to be having more compassion conversations, because we need to be considering all of the above in our interactions.
I agree. And I think, there are a number of statistics out there in a number of different papers that I present on often. The CDC reports in the next about 20 years, we're going to be a majority minority nation, right? There won't be one large representative group.
Yes.
And I think in knowing that and knowing where we've come in the last, even just 2 years since George Floyd and where we are today with the neurodiversity movement and behavior analysis, it's time for us to not only speak about this stuff, but to acknowledge our awareness of it. I think that as practicing clinicians listening in on this call and the ones that I have the honor of working with daily, we are working with patients of so many profiles, so many cultural and subcultural groups that they belong to. And when I say culture, it's not just your country of origin or the language you speak, it's the region that you live in, right? Yeah. It is the groups that you participate in. If you have family that play sports, that's a part of your culture. So those groups that you participate in, and Skinner said this, those social groups are the groups that reinforce your language and your behavior. So you are shaped by those contingencies. And I think as behavior analysts, to really understand our clients and what's socially appropriate in terms of targets, we need to understand the entire social construct of their family and that makeup. And I think it's time to talk about it. So we're not just treating that child that walks into our home or into a clinic for an evaluation, but we're also trying to understand what role does the family play, right? Are there other individuals that make up caregiving, like grandparents and aunts and uncles and cousins, and how much a part of this process are they, and should they participate in support treatment? I think that there's a big piece of capturing and understanding a family's culture, their dynamic, where they participate and belong, and developing objectives and goals according to understanding the entire system.
Let's talk a little bit about kind of definitions here. I mean, there's a lot of terms, like that have the word culture in it. And so for a lot of years, it was cultural competence, cultural sensitivity, cultural awareness. A little more recently with papers, there's been cultural humility. I've been hearing a lot lately, particularly in terms of work with Indigenous populations around cultural safety. And now we're talking about culturally responsive care. It seems like all of these things are, kind of one and the same. I think we need to stop making up phrases. It's starting to get a little bit confusing because do I have cultural humility? Do I have cultural competence? Do I have cultural awareness? Am I being culturally responsive? So, what does culturally responsive care mean, and why do we call it that?
That's a great question. I want to go back to the topic of cultural competence first. And I know that Patricia Wright, she wrote a paper in 2019, right? And it's a fantastic paper in that let us rephrase cultural competence and call it cultural humility. Because one, we're never going to be competent in anyone's culture. I could walk into a home and that client could be a first generation Thai American, just like myself, but their culture could be completely different because of their social constructs, where they're raised, their family values, their parenting styles. So I would never be competent. I could become humble. I have a number of stories where I have been humbled, and I continue to be humbled in my career by families and colleagues. But in cultural humility, that means we're lifelong learners. We are willing to learn about every unique and individual client that we get to work with, that we will do our best to engage in self-assessment of our own biases, right? If there's an unconscious bias that might pop up or we're working with a family, that we're going to do the work to uncover that bias. I think that cultural humility is a better phrase for where we are as a field currently, right? We're still investigating this new the ethics code that was released in January regarding, I think it's 1.07, cultural diversity and responsiveness. What they talk about in this, and one, we know that it's not the requirement to have CEUs in cultural responsiveness doesn't come for another 3 to 4 years. But I think the field, we're starting to begin to consider, what does that look like? Where is this training coming from? Who in our field is equipped to train? And whenever I talk about this, and what is cultural responsiveness, it's one, and it's identifying that we all have different cultures that we belong to. And the best way to serve our clients ethically is to learn their culture, their very specific and unique culture, that we're not going to find that in a textbook, right? That it's listening without an agenda. It's being compassionate, being empathetic. It's understanding that sometimes when I walk into a home and meet a family and I've got, my intake packet that I need my 20 questions answered on, I might not get through one of those because maybe the parents are grieving and they're super emotional about a diagnosis. And my role is going to be just listening and supporting. And I'll come back next time and we'll conduct that intake. Cultural responsiveness really is finding ways for us as professionals to learn about our own culture and then teach our colleagues about how to manage that in those cultures. And I mentioned earlier the humility of it. So I will say I was in a situation recently. I was in a clinical director type role, and this was right after George Floyd. And I had a number of BCBAs that I was supporting. So I wasn't their direct supervisor, but I was kind of their support line when they were struggling. And in the South, we had a number of African-American clients in one region. Yeah. And the parents were asking for a statement saying, hey, this happened to George Floyd right down the street from the clinic, and we'd love to know what your organization is doing. How are they going to support our families? Or are they going to come out with a statement on Black Lives Matters? Our clinicians at the time were not prepared to answer these families. So I hopped on a phone call with a mom. And I said, look, I'm in a different state than you are, but I support and oversee this territory. I want to listen and listen to you. I just want to have a conversation to support you. And this mom said, look, what happened to George Floyd, this could be my little Black boy. This could be my son who is highly aggressive. He doesn't follow instruction. No one has instructional control. And you're sitting in another state trying to help, but you don't know what I'm going through. And you know what? There are 6 other little boys in this clinic that look like him and they can't communicate. Are you telling me that your team is prepared to help him become compliant and follow instruction? What if, this happens to him in 10 years? And I would say I was very humbled in that this is a situation I had never been in as a supervisor. And here we have parents that are scared. They're scared for their children. And our role is to explore, how can I support this specific family, right? I am not from the same culture. I know my role and my expertise in managing challenging behavior and skill acquisition. But right now in this moment, I need to support this mom in a fear that is a legitimate fear that is playing out in modern day. And those are the scenarios I think that the more we share as BCBAs, the experiences that we have with different families. And again, going back to the compassionate care talk and what Bridget Taylor and colleagues wrote in that paper is we need to admit when we're wrong or when we don't have an answer. I think that's the first thing that we learned, or the first thing I learned in working with Dr. Taylor was there are times when as behavior analysts, we don't say, you know what, that didn't work. And I need to figure out what the next intervention might be. So with this mom, I said, I am so sorry that you're struggling with this. And I 100% am here to support you. Let me hop on a team call with your clinicians. Let's figure out, if we need to talk about different objectives for your son and how we can accomplish this. This is a legitimate fear of yours. And I want you to understand that I hear you and sharing that I will do whatever it takes to help that family.
Awesome. Kind of related to that. So kind of tossing around these thoughts in my head for quite a while, long before you and I were going to have this conversation around. Well, first off, I think it's sort of the whole bias thing and kind of recognizing your own biases. And that seems to be sort of the, central sort of tenet of all of this stuff. I mean, it doesn't matter. It doesn't matter if you're, racist or classist or sexist or ableist, and any ism in the world is basically a result of bias. I have so much bias that I'm learning about every day. And that's all a product of our learning histories and our culture and growing up and media and everything. And I like things simple when it comes to sort of action items. And so, for me, sitting and recognizing my own bias and in every situation before I get into it, which I'm not very good at yet, but that's sort of the goal, is to, before I get into a situation, think about all of the judgments I'm about to make and the biases I'm about to have, and whether they're racist or sexist or ableist doesn't matter in that moment. They're all potentially problematic. But that said, I think it does help to have. I'm curious about your thoughts on this. Do you think it helps to have some sort of, basic general knowledge of sort of, cultural issues in different groups? So, for example, I think it's finally gotten out to the world that the black people's interactions with police can be very scary and very dangerous, and it's a realistic fear of death every time they have those interactions. And so I think knowing that, in advance can help in my interactions with a family and what they're working on. Obviously, I'm not going to impose that's going to be an objective or anything, but it may change. It may change the questions I have or the conversation I have. So I guess the question is there's sort of cultural responsiveness where you're kind of coming to a new family, asking lots of questions to sort of
open-ended, right?
Exactly. But at the same time, is there a value in having some cultural competence before you go in? Obviously, you're not going to generalize, just like you said in the beginning. Every Thai, a Thai American family is different from the next Thai American family, and so on and so forth. Obviously, there's a lot of differences there. But would it be helpful for me to have some basic understanding of some of the common, maybe cultural norms of, say, of Thailand? Are you a BCBA supervisor looking to streamline your practice? Or maybe you're working towards your BCBA and need to find the right supervisor. Homehouse offers tools that make supervision so much more enjoyable for both supervisor and supervisee. For supervisors, they offer easy meeting documentation, competency tracking, monthly verification forms, a built-in supervision curriculum, and so much more. For supervisees, Homehouse has a fieldwork tracker with built-in auditing, monthly verification forms, a curriculum, quizzes, and more. If you're looking for a supervisor, they even have a supervision marketplace where you can connect with BCBAs until you find your perfect match, kind of like professional dating. For more information, go to whomhouse.com/speak or search Whomhouse on Google. If you're planning on collecting continuing education credits for this episode, you'll need to enter the 3 secret words at www.cbiconsultants.com/shop. The first secret word is contextual.
That's a great question. I think that, and this kind of relates to that ethics code of culturally responsive care, and that we can do the work. We can try and find the literature, or, I wouldn't go talking to my friends that were of that same group because it's going to be a very different experience. But there's a text I'm actually looking on my bookshelf by Connors and Capel. It's multiculturalism and diversity. And they actually have chapters for very many different groups. So they've got an entire chapter on how to work with Asian American families, how to work with African American families. There's one on Indigenous families. Now, this is a great text in that it'll lay a little bit of a foundation in some questions you might want to capture in the intake process or when you're working with these types of families. But I think that we also need to be aware that we can't be going in with these preconceived notions, because again, we're bringing our bias in. If I go in assuming every Asian family I work with is going to be English as a second language, I'm making assumptions that are going to harm my ability to be an effective practitioner when I work with that family. I like to train. I do a lot of training of clinicians in how to conduct an intake meeting, how to administer assessments. I like to train with go in completely open-minded to and having the time to conduct a history assessment of that family. What brought you here? What preconceived notions do you have about ABA? Because some families will have preconceived notions. They're also going to have a bias in meeting us, right? Bailey and Birch in 2010, when they wrote that book, 25 Essential Skills for Practicing Behavior Analysts, they said the most important meeting is that first meeting you have with a family. And I think that's 100% true. And that's your representation for the field to this family. So I think for us, going in completely, almost like a blank slate, I'm here to learn about you. I have some questions I need to gather to inform my, my assessment. If I'm billing, I've got certain 97151 codes and units I have, but really I can't serve you until I learn as much as I can about you. And one of the things they recommend in, I know Fong and Tanaka's paper, as well as Matsumi in their papers, is truly understanding not only that family's cultural background, but how does that family value healthcare, right? Especially if you're working in the United States under insurance reform,
right?
How does that family respect those healthcare providers? Do they expect when they go in, right? You go into your oncologist, you're expecting their expertise and you're going to follow that treatment protocol to a T. How do they value healthcare? Do they maintain their appointments? Those are questions you could ask. What are some other service professionals your child is working with? What is the frequency of engagement? Do you go to all of those appointments? That will allow you to determine how they feel about your recommendations when you do make them. So I think going into each family, I think coming in with the bias is going to be a little bit harmful. I think that there is some work that can be done in, looking at literature that's out there about a group, just to kind of be prepared to know that I've heard this is hard. I personally am not of this background, but I've seen people struggle with this, or I've heard that. However, how's your family doing? What are some barriers for you? I think that's a better approach than going in already informing your own bias, so to speak.
Yeah, I really like the question you said about asking them kind of what their perceptions of ABA and whatnot are. Right from the get-go, because especially this day and age where, I think our field is going through a lot of changes and conversations around, a lot of the stuff in our past, as well as, how some of that stuff from our past has carried over to the present. And there's there's definitely a valid concern from a lot of practitioners that families are maybe having a different opinion of ABA than they might have had in the past, and whether that's misinformed or not. They may already, like you said, have these biases the moment they hear someone in ABA is coming over to their house. And so I love the idea of checking in with them and seeing what their feelings are and maybe having that honest conversation early on.
Yeah, I think it's smart. And I think that's, again, I refer to this text often, but Bailey and Birch say that at that onset of services, families should know what to expect from you and what to expect from your services, but they also need to understand. And I used this example recently, and I gave this talk at the University of Washington. But when my daughter goes in for dental work, right, and she's got her mouth full of like cotton and all that, she can't speak. The dentist will say, "Hey, if this hurts, raise your right hand. If this is uncomfortable in any way, raise your right hand." Our families need to understand they can raise their right hand at any time, and they need to understand what that looks like. I'm going to raise my right hand. I'm not comfortable with my therapist, with the intervention. I didn't agree to that treatment. What are the steps I follow now? Do I contact your supervisor? Do we have a conversation? I think that as practicing behavior analysts who are working in a very seemingly medical model, everyone needs an out, and they need to know from that first meeting what the expectation is, and that this isn't a lifetime of a commitment. And they need to be able to raise their right hand if they're feeling any discomfort in the interventions that we're applying.
Totally. I love that. Well, let's talk a little bit about kind of assessment, because I know you talk a lot about sort of doing, essentially a kind of a culturally kind of informed assessment practice.
Yep.
So kind of a two-part question, because I feel like sometimes we confuse what the word assessment means. Sometimes we think assessment means using these, sort of curriculum-based, questionnaires, or maybe like an open-ended functional assessment from, Hanleyland or whatever, as being, that's what assessments are. And so where I know assessments are really just asking questions and trying to get a picture of kind of what's going on and what's needed and so on and so forth. So kind of a two-part question maybe here. And this could take up the rest of the interview. But one being kind of, what's it mean to have sort of a culturally formed assessment? What kinds of skills and types of questions should we be asking, and what does that look like?
Yeah.
But then also, and I can ask this again if it takes a while to get there.
If I forget.
is sort of how do we use already created assessments? So you mentioned, like ABLLS and AFLS and those sorts of things. And administer them from that sort of culturally responsive perspective, because I know I've heard from some folks that some of those assessments are a bit dated in terms of considering some of these cultural pieces.
Great questions. And yes, I could go on forever. I feel like this is a lot of where I am currently in my career. And I always want to say, when I look back on my career, I've been doing this since I was in my late teens. I feel honored that I'm in a different role now. I get to work with behavior analysts and train them daily and special educators. And it's such a fun place to be, to help shape how they administer assessments. So to your first question about how we bring in cultural components into the assessment process, I reference often Tanaka, Matsumi, and Higginbotham paper from 1996.
Yes.
It's the culturally informed functional assessment. It's an old paper, right? Yep. It's been around for a couple decades. I love it. I review it for a lot of, I have a colleague who calls, when you read a lot of information, you pull out the gems. I review it for gems. There are a lot of gems in it that contribute to how I view the assessment process. And a couple things that really stand out to me is, one, right, we need to, and we've talked about this a bit, we need to do an entire analysis or assessment of the family's cultural variables, meaning, and then we can go to even Bigland's on, contextualism here, in that we need to understand how the family views society, their role in society, and then their child, that client's role in the family, in society. So we can look at that family from those views. And if we embed those questions in our intake, right, that's going to help us gather that information, and saying, okay, I'm not here to serve this small function of just this, these 40 hours a week for your child to meet these goals. I'm here to serve your entire family. And in saying this, and I'm going to kind of go off topic and try and come back on topic, but in saying this, one of the other things that I train heavily on is, as practicing behavior analysts, when we meet with our parents, yes, we cover the treatment plan and the goals of the short term and long term, but we also have difficult conversations. And those difficult conversations include, your child is currently 4. Where do you want your child to be at 15? And then again at 18. And oftentimes I'm met with, at least in my experience, has been, I'm not ready, we're not thinking that far ahead because they're 4. But as clinicians and practitioners, we need to think, I'm setting up this plan and I'm looking at what are the objectives to increase your child's independence, right? And I know we talk about optimal outcomes as a field. That's a huge topic right now. I think we're all trying to crack the code. What is an optimal outcome for a client that we're serving? We all have different perspectives. Is that decreasing hours, least restrictive environments? I personally, from literature and different special interest groups I've met with, I think it's increasing the individual's independence, right? Their access to reinforcers, their access to their environment without supports. But the other one that is really hit heavy for me is increasing that individual's ability to advocate for themselves. Their ability to, whether that be join the IEP and say, hey, I don't need this support, because I've had a couple clients who come to the IEPs and they say they're so happy to see their whole team, but they're very much like, why are you all talking about me? I'm doing fine. But also increasing that individual's ability to say and to assent, right? We know that's also a topic we're talking about heavily. Our ultimate goal is that we get to determine what interventions happen to us because we are, we have our ableism. And that is the ultimate goal for our client, is we want them to assent to the interventions or the lack of interventions in their life. So I think an optimal outcome for me with the clients I serve is I want to build that independence for you. And in doing so, I need to look at your treatment from a contextualistic view. So I need to know where you fall within your family, how your family views society, and where they fall within, again, when I say society, not the world at large, but their social groups that they operate in, and how can I help you become independent in those groups? And I know I went a bit off topic, but I think how we incorporate that into intake and then intervention is one, and this is a question that came up in an assessment course I taught. We need to have those cultural questions included in every client's intake, not just the intakes where that client is a different background from myself, because there are some times when, I've had a BCBA say, I'm not comfortable asking these questions because then it shows the family that I noticed that we're different. Well, then don't ask those questions. Make it a part of the organization's intake packet, right? It's the question that every family answers, whether they match their clinician or not. Every family should say, what languages do you speak? Do you need a translator? What social groups do you belong to? Even regionally. Yes. I think those questionnaires should be included so then everyone has that same access to reporting.
Yes.
What makes them unique.
Yes. I think that's really important because also, this is also bias. There's this assumption that you're only different if you look different. Right. And,
that's right.
And
I think, right.
Yeah. I mean, something, we're seeing a lot here as I learn more about sort of, indigenous groups locally and trying to sort of build my understanding there. There's a whole large group of indigenous folks. I think primarily in kind of what we call Central Canada, called the Métis, and the Métis peoples are in. There's a whole they're from an area I think called it's not Six Flags. I know that's the amusement park, but Treaty 6. That's what it is. I knew there was a 6 in it. The Treaty 6 territories, and they're from that particular area, and there's a whole lot of ceremony and sort of culture associated, but a lot of them present as if they're Caucasian because of some of the mixed race marriages that happened sort of early in like the sort of 1600s to the sort of the 1900s and whatnot. And there's I'll put a couple links in the show notes for folks to learn more about the Métis peoples, because that's not sort of the focus today. But point being is you could easily walk in and see someone from with Métis heritage and make a lot of inaccurate assumptions, that they're essentially white identifying cisgendered folks and so on and so forth. And so that's just a long-winded way of saying, I love that, we're going to ask that question to everybody, because you just don't know.
Exactly. You don't know. And I think that's, again, when we go back to that cultural responsiveness, it's, I think organizations, and as our field is moving there, we need to ask everybody, because we need to assume, right, and not having assumptions, we need to assume we need to learn everything about everyone. We are not going to have and I'll share an example, but we need to basically take on the responsibility of capturing information for everyone, for lack of a better word. But my married name is Van Etten. And it's very much a Dutch name, right? Yep. Just in hearing it, it's Dutch. And I live here in Austin, Texas. And a lot of times when I schedule appointments for myself and my children, it's Miss Van Etten, we're going to be coming in. I've had 4 scenarios where I walk in and the first thing those receptionists or whoever it is we're meeting say is, "Oh, wow, you're not a Van Etten," without even realizing how disrespectful and biased that is.
100%.
And I mean, the first couple times, when we moved here, I would just smile and say, "No, that's my married name." But now, and this is maybe me being a little more feisty, I've come back and said, "What does a Van Etten look like?" I don't understand. Because I've also used my maiden name and they can't say it, right? I've heard artichoke and Intarachote, or I'm sorry, I can't say this. Can you spell it? So I think, for those of us that might have names that are difficult to pronounce, or we come from a different background and culture than, the majority of the population where we're living or we've grown up, it is, those assumptions are painful. They're painful, and they help. They've helped me at least shape how I interact with families of different backgrounds, how I approach the treatment, because I never want to make them feel the way that I feel when people make those statements towards me. And I'm raising mixed children, and they lived in Hawaii for a couple of years, and now they're here in Austin, Texas. And for them, it's been a difficult transition because in Hawaii, we were a majority. The majority of the population is, Hapa, or half Asian background and heritage. And, that was a unique experience for them. And now being here in Austin, we're very much a minority. And, we've lived through a number of different experiences here after 7 years where they questioned if they belonged here. They questioned, is it like we don't see other kids like us? It's shifting a bit. There's some other families moving in, but it was a difficult time for them. And I think that, again, working in the helping industry, we need to learn through podcasts like this, through talking to colleagues, through talking to friends, that everyone experiences life differently. And the color of the skin or the name that's on your certificate is not going to shape who you are. It's your lived experience. And the only way we can capture that information is by, compassionate care, interviews, conversations, listening, versus making those assumptions.
Going to kind of the part B of that question was sort of, how do we then kind of culturally adapt some of these assessments protocols and things that are out there, because they're very, some of them are, they're pretty rigid, and they're supposed to be, because they're objective, does Billy do A, B, or C, but often A, B, or C is culturally specific to white families or whatnot, and so, I think the classic example that I've heard on several podcasts now, the interviews that I've done, is the eating with a fork or eating with utensils, and that there's quite a few cultures that, that don't use utensils, and that's the regular way everyone in the family and everyone in that culture group eats. And we're going in and seeing, what we judge to be messy eating, or poor manners, or whatever term you want to apply to that, and right away we're starting to teach these skills. And I think one example that I heard recently was, with that sort of context, was obviously if you're going into a family and you're talking and you're saying, well, I think we should teach them to use a knife and fork, and the family right away is like, no, that you can nip that early. But often what happens is these kids are in other settings like schools, and so the school starts insisting they use a knife and fork, and then they come home and and there's generalization problems, and it actually just creates more of a mess than there was originally. So So how do we take these assessments that maybe are going to change down the road, and probably should in some way, and administer them while being culturally humble and
sensitive,
and sensitive.
Yeah, that's a great question. A couple of things, and depending on when this airs, we'll have some updates here at Central Reach, but we're currently working hard to move in the direction of, we're working to combine the ABLLS and the AFLS assessments. So this will likely come out after that goes to market, but that's a big push that we have here. In that one, we know that when we look at assessments, right? One, the definition of assessment, and I'm not going to give you the dictionary definition, but truly just an assessment is capturing a snapshot of that individual's ability at that moment of administration, right? So perhaps that individual knows so much more than what you captured, but you've got your assessment in front of you, you've got the time to spend with them, and you're gathering data, observing, capturing using face-to-face interactions, informed, questionnaires, as well as interviews. That assessment is your ability to determine what to work on next. What skills does that client have versus what do they not have? And then where do you begin intervention or treatment? I think as we get ready to kind of move in the direction, at least from my role here at Central Reach, to combine the assessments, we're also looking to update the assessments. I think, modernizing, making sure that we're aware of where we are currently in space and time, that we have clients that aren't going to identify to one or two genders, right? Male or female are in a lot of these assessments, that needs to be shifted as well. So that is something that we've talked about as a team. But in what we have currently, so let's think about all of the assessments that we get to administer as behavior analysts. When these assessments, especially the criterion reference assessment, so like the ABLLS, the AFLS, the BBMAP, these assessments, some of them have like to score a 4, you have to demonstrate 200 nouns. You have to be able to label or select. It doesn't indicate exactly what those nouns are. So when the goal is independent feeding, and it might suggest fork or spoon, I always recommend select the utensil that is socially significant to the client. To master it, it might say fork or spoon in the examples. It doesn't mean it has to be a fork or a spoon. It can be chopsticks or, their fingers if they eat finger foods. But I think a lot of that requires us as practicing behavior analysts to just write up what we've observed. So if you're submitting to a funding source and you're saying they scored a 3 out of 4 on independent feeding, well, the 3 meant they can use chopsticks and fingers, have discussed with parents, perhaps bringing in forks and spoons if appropriate, but not at this time. I think there's a lot to be said about administering these criterion reference assessments, but then again, going back to the crux of what we do, individualizing what we've observed to ensure that when we're reporting on what is in this assessment, this is truly what I observed and what is appropriate for this individual in front of me in this assessment. So I think there's a piece of bringing in the culture, bringing in, I had the conversation with a colleague recently where a lot of cultures don't engage in eye contact. That is not a requirement. That is not how they communicate with one another. So that would never be a goal of a client of mine that would come from that type of family, right? And if greetings, I know in the past, as a newly certified behavior analyst, greetings were hello, hi, how's it going? Well, some families don't even say hi, right? They just acknowledge each other by glancing and shrugging their shoulders. So again, selecting objectives that are salient for the family, that are socially significant. And then I always recommend making sure the families agree and approve the target selection, especially if you are bringing in a large cultural component to it. I think that's very important.
So, absolutely. I love that. Although I don't know that, I hope when folks listen, some of them will start doing this, but I feel like most folks still, aren't doing these sorts of things. So is Central Reach now sort of, you said you're combining the AFLS and the ABLLS. So does Central Reach kind of, what's the term? Like, do you own these assessments now, or how does that work? Like, or are you just sort of working with Partington and folks, or?
Yep.
So yep, you own them?
So we own the assessments now. Okay. Yeah.
And so
that's the big question.
Yeah. And so if folks are, is something that we're going to see in the future, or we see now when folks are sort of purchasing these, that this sort of culturally sensitive administration of these assessments, is that going to be kind of built into them now? Do you know what I mean?
So that's not a part of the current, I completely understand. So we don't have them built in yet. We haven't completely updated in terms of objectives within the assessment. When we provide training, now that we own them, I've created an entire CEU around how to build in cultural components into the assessment process. So taking the assessments where where you might build in, culturally responsive questions, where you might notate some of that, and then how you might shift your intake packet to inform culturally sensitive questions.
Ah, very good. That's cool. That's cool. And then how are you, what's sort of the best way to kind of, train clinicians to be, culturally responsive? It seems like we can give them lots and lots and lots of facts, and lots of ideas, but how do we sort of assure they're learning these things?
I think a couple ways. I think the BACB has done a fantastic job in that it's now a required CEU requirement, right? Not currently, but in the coming years, it will be a requirement. I think, and I brought this up in our podcast, The Behavioral View, I think we still need to figure out who is teaching this information, where we're gathering the information, right? If it's a requirement of a CEU, who are the experts in the field that will begin administering these CEUs so that we can all learn? I think that we can use the gold standard of training, behavior skills training. I think that, supervisors should also learn about this stuff and engage in these conversations. We're going to role play this scenario. I'm going to be a family who brings this situation up to you. You are the practicing clinician, and let's role play how you're going to respond. I think, and I had this thought the other day, those of us that pursue training in culturally responsive care, it's a passion, right? There are motivational variables at play that contribute to that desire. My own motivation was my own experience growing up. I've experienced racism in different facets. I've experienced people placing their bias on me in different ways. I experienced it even today in 2023, which, as a child, I thought this is going to be gone by the time I'm a grown up.
Wow.
Right. People making fun of me because my eyes are slanted or because my family eats rice and fish sauce. For sure, by the time I'm in my 40s, it'll be gone. It still exists. I think as a society, we have a lot of work to do. And as a field, we have a lot of work to do. But I think learning and being open-minded to learning from all of the different people, we get the privilege, but, our social groups shape who we are. So if you are, and this is something I learned in my master's coursework, if you are surrounded by people who are like-minded and they're always agreeing with you, it might behoove you to change your social circle to start interacting with people who disagree, right? Just to learn and to have these conversations and learn how to engage in them in a way that is positive and supportive of your own experience and shaping. I think that's one. And two, I think there's a lot of professionals in our field that are starting to write about this. We're moving in that direction. Conferences, DEI committees at different organizations, participate if you have a desire to participate. And then lastly, other allied health professions have done this. They've tackled this. There are a lot of literature in nursing, palliative care, oncology on cultural responsiveness and diversity, and the requirement of these individuals to receive training in these areas. So if there is nothing in behavior analysis, and those are the journals you love to read, I urge listeners to look in other journals, look in the Journal of Nursing and the Journal of, Patient Health, and see what they've done in their field.
Very good. You touch on a couple of point. I agree with going outside of just our journals for everything, like not just for cultural competence. I mean, I think there's certainly, certainly like I know Dr. Camille Kolu has really hammered in when you want to learn about trauma, behavioral analysis journals aren't the place to find the info. We're starting to see some stuff. I know there's a trauma-informed behavior analysis issue coming up soon in behavior analysis and practice, which will be great. But a lot of other fields have been talking trauma for a lot longer than we have, and so it certainly doesn't hurt to kind of check out these other groups. Thinking about sort of this this BACB thing in 2027, it's interesting that the BACB wants it's great that they're going to have these sort of cultural CEUs, and I know that the QABA already has their DEI CEU, and their recently formed IBA has their cultural CEU, and so it definitely makes a lot of sense to kind of have those. I hope that the BACB is not going to be sort of expecting that the folks that are teaching these or that are offering these CEUs are just BCBAs, because as of this year, they're no longer certifying folks outside of North America, essentially, with a little bit of certification in the UK and Australia, which, that's a different conversation. But the fact that, the fact is we're now going to require folks to have CEUs to learn about other cultures, but we're essentially only going to certify people from other cultures if they live in the USA. Yeah. And so I hope that there'll be some openness to CEU providers from other parts of the world. And I hope, this isn't a question, this is just some soapboxing here.
A statement?
That there might be some room to look at sort of being a community, an approved continuing education provider, from outside of the US, even though you can no longer be a BCBA. Because I sat on the IBAO's professional advisory board when they first started, and I was with the group that kind of came up with the idea of the cultural CEU. And the reason we came up with that was because I think I came up with the cultural CEU. I don't know, but but the reason is because I think because it was right around again, sort of George Floyd, and this real need to sort of start addressing biases. But B, because we were now going to start certifying people in so many nations around the world, and so it made a lot of sense in my mind, I think in our mind, that we be able to provide we as not myself, but they as sort of these other countries certifying people, being able to educate each other on their different cultures. So if you have someone in Botswana, they can tell someone in Kenya, what's happening, or in Thailand or wherever, and be able to sort of share knowledge and sort of, build sort of a bigger community kind of internationally. I hope that the BACB is thinking about these things, because there are so many great professionals around the world. I would much rather talk to someone who lives in Botswana versus someone whose grandparents lived in Botswana. You're going to learn directly from the source. To kind of get those perspectives. So, I hope we see that. And it makes me think about kind of, representation in our field. And I don't know exactly what the question is here, because I want to say this properly. Is most of our professions, most of our BCBAs, our board certified folks are white. I mean, we've got those stats. It's like 92%, something like that. And so, which speaks to obviously the importance of culturally responsive care and cultural humility and learning these pieces, because we have a lot of behavior analysts going into homes where they don't look like the folks they're serving. But I guess the question is, number one, do you think what I'm getting at, I guess what I'm wondering is about, because from talking to sort of folks like in these other countries, so I did an interview with Adair Carden in Senegal. We talked a lot about this, and then another interview with someone kind of works who's Arab and works with kind of those populations, and how important it was for a lot of these families to have someone that looked like them come in and be their professional. Like how much more effective things were, especially with the language, because they're speaking the same language. So she's from actually from Washington herself, but she said, I'm not going to get sustainability here in Senegal until I have Senegalese behavior analysts, that are speaking the language and aware of the culture and actually have been, part of that culture. And it's just never not going to be the same as having, someone like myself coming in. Do you kind of agree with that statement, I guess? And maybe what do we need to do to get more representation so that we can have more of that kind of happening? Do you know what I'm trying to say? And you see why I'm struggling to say it?
I know, I completely know what you're trying to say. Yeah. And I think that there are a couple of ways to approach this. And I think I'm in both agreement and disagreement for a couple of reasons. Yeah. One, representation does matter, right? Yeah. I think as a minority woman in our field, who has struggled in climbing the ladder herself, that I didn't see counterparts like myself in leadership positions. Yeah. So it wasn't like I looked around and said, oh, you know what, there's so many Asian American women holding these roles that I'm applying for. It was, and even I think I shared this in a talk I gave that kind of received a lot of credit on LinkedIn. I had a supervisor early on. And so 21 years old, right? I'm young, I'm new into the field. I'm really loving behavior analysis. I'm pursuing my master's. And my supervisor at the time was white. She was Caucasian, and I was teaching a little girl how to ride a bike. Right. And I was on my hands and knees in my Converse because it's so much more comfortable to run a session in Converse, pushing the pedals on her bike. And my supervisor was walking alongside next to me in her high heels. And she looked at me down on my knees, pushing the pedals, saying, I don't know if this field is for you. I actually don't know if you're going to make it as I don't know if you should pursue behavior analysis and become a BCBA. Wow. And that moment for me was so representative of what's driven me, because it's like, one, I have this woman who's standing above me as I'm on my hands and knees, and she's wearing high heels while we're teaching a child to ride a bike, and telling me I can't make it in this field. So that was a little bit of an MO for me to really push through my career in ABA many decades ago. But going back to your original question, the reason I don't agree with that is, and Connors and colleagues wrote a paper in 2019. They talked a lot about developing the cultural awareness skills of practicing behavior analysts. And what they said was, we need to support a wide population of individuals in getting into behavior analysis, right? Of all different backgrounds, whether that be the minority background, neurodiversity, all of those individuals need access to our master's programs to become practitioners. Yeah. However, having a diverse group of practicing behavior analysts doesn't necessarily equate to more culturally responsive professionals, because we're not ever going to be able to match the number of clients that we serve with an identical or a similar background or similar experienced practicing behavior analyst. It's just never going to happen. But what we can do is we can ensure that every behavior analyst that is out there in that certificate registry is culturally sensitive, culturally responsive, and culturally humble. And we can do that by having requirements of, skill demonstrations. If this is a topic that is truly one that we want to stand behind, just taking a CEU is not going to be enough, because we can do harm if we're making assumptions and bringing in biases. We can do harm if we say, I'm culturally sensitive, and I say something wrong that does harm my client. So I agree that I think that, especially in different countries in the nation, it's better when they speak the same language, especially if you've got a family who cannot communicate in the language that you're delivering services, or a translator that is very well versed in our science. But I don't know if we'll ever be able to meet the needs by matching clinician to client. So I think that the best thing to do is continuing to have conversations, right? Engage in that self-awareness and self-reflection of your own bias, and read and consume literature and listen in on podcasts to understand, wow, I didn't realize that I did this, or, oh gosh, that story sounds like something I've done in my past, or I might have said this to a supervisee. I know I would never have told a supervisee that they weren't going to make it in the field. Definitely not in that language. I might have said, hey, here are some ways that I can help you become a better practitioner when you become a supervisor. But for me, again, as a minority woman, having a Caucasian supervisor stand above me and make a statement like that, it felt like I was never going to be anything in this field. I don't know if she's listening today because she's no longer in this field, but
that's where I was wondering.
I'm
not surprised. Yeah. I mean, a person in high heels standing over you is talk about, flashing the power dynamic, or trying to create one anyway.
Yeah.
But the high heels versus the Converse, you could really tell sort of who was going to be in the field the longest right there. Did you know that you can advertise your products, services, and events on the Behavior Speak podcast? We offer packages for both new and past episodes. As April is Autism Acceptance Month, to celebrate and uplift autistic voices, we'll be offering free CEUs for all of our episodes which featured autistic guests. And we offer a special package with an advertising slot on all of these episodes for the whole month of April. If you'd like me to send you our media kit with more information, send me an email at ben@cbiconsultants.com. That's ben@cbiconsultants, all one word, .com. The second secret word is view, V-I-E-W. Yeah, no, just thinking about language for a second, because I think that's where the, there can be a lot of issues in terms of language. How does it work in the States with sort of insurance? Does insurance cover things like interpreters?
It currently, in my experience, it does not. Depending on, well, okay, I shouldn't say it that definitively. I think that as a behavior analyst, if you have a family where you do need an interpreter, you'd have to reach out to the case manager through the funding source. So if you're working with a specific insurance program, you might reach out and say, I have a client who has a need for an interpreter, and the insurance would have to support that process. I also know in my experience working in regional centers, they have a large number of interpreters available. So depending on which funding source you work in which state you work, a family may or may not have access to interpreters.
Because I wonder about
to support, services acquisition.
Right. Because I wonder about language. Because if you're working with a family where, there's no English at all, or very little. And so you do need a translator to come in, or you need to speak the language. If you speak the language, great. That's, certainly going to be probably the ideal. But if you don't, I'm wondering if there's sort of cultural considerations for using an interpreter, because the interpreter might not be translating things properly or the way you want it to be.
Exactly.
And B, they might not be culturally competent, and therefore they may be expressing your message in not the way you want it.
Yeah, I agree. And I've had a very similar scenario in my clinical practice, in that when I looked for an interpreter, I looked for an interpreter that, when we spoke about the case, could speak about it in a way that I agreed that they were understanding what I was saying. Right. I didn't use my heavy behavior analytic jargon. I definitely made it user-friendly in a way that when they spoke it back to me, I said, okay, that's exactly what I'm trying to accomplish here. And they would translate it. Now, one of the things that interpreter said to me at the time was the way I'm communicating it or translating the language isn't the way it's said in English. So a lot of, the verb nouns are backwards. So the interpretation, again, is a little bit different anyway, because of how it's translated. So I've worked with different families where recommendation included written. So if I have families where language is a barrier to communication, I always follow up with very clear instructions via email, right? Because written word is a little bit easier for those families to digest, especially if they can read English. Now, I've also worked with families where we had to translate the written word into their home language. And that was also difficult because, again, like you're saying, that interpreter may not rewrite it the way that it's intended to come out. So I think that in those scenarios, now, when we spoke just a few seconds ago, this was about families that probably spoke English, right? So we were, again, making the assumption that in these culturally diverse backgrounds, they all spoke English. There are going to be scenarios where your clients do not understand what you're saying, and you have to rely on an interpreter. And I think that is an access to care situation that we have. And, I love that you're working in this international certification realm, because there are brilliant behavior analysts outside of the United States that, can and do provide services. And I think that, again, building a community of access requires that we consider access in other languages, access in other texts written in their language. I think it's important. And I think when you're looking at interpreters, I've seen some recommendations on social media to use the Google interpreter. I would always refrain against that as a recommendation, just because, again, the way it's translated is never truly the way it's been spoken in English. So always having a live interpreter first, and then secondly, having someone who has experience is always best. If we had a community where we could reach out and say, I have a new family, they moved here from, this nation, is there anyone in our field who can help me? I mean, that's a great place to start. I haven't seen anything like that, but I imagine that's something that we need to be considering.
That would be an amazing company to start, behavior analyst translation, where, where folks, maybe they're BCBAs themselves, or at least, they have, some basic understanding of the jargon, RBT level or something, to be able to sort of then provide, behavior analytics specific consultation translation. That'd be really neat.
Absolutely.
I think it would also be, and I'll do another sort of shameless plug for the IBAO here, where I think I highly encourage, BCBAs that are maybe working with families where, language is a barrier, that there are a lot of behavior analysts around the world now that are doing a great job of translating kind of ABA literature. I've seen the white book coming out in a few more different languages. I know Greg Hanley's team and at FTF there have done a really good job of getting, the PFA, in translated into sort of multiple languages. And I believe some of the translators are folks that are also working with the IBAO board right now. And so, do you see a lot of folks doing that sort of thing, sort of translating their own documentation within their company? So if you work sort of in a like, for example, in the area I live, we definitely in sort of greater Vancouver area, I'm kind of a little outside of town, but there's just what you say about sort of, minority populations becoming the majority, as it were. There was a point, and I don't know if it's changed, but 5 or 10 years back, where greater Vancouver, the Caucasian population was the third highest, before I believe it was Chinese families and East Indian families. I think it was East Indian, then Chinese.
Wow.
And so, we have predominant, so in a population of, say, I don't know, a couple million, there's a good chance that, well over, 1.5 million of those folks are either East Indian or Chinese. And so I've seen companies here, mine, the one I work in now, and a couple I've been in before, who made a point of translating all of their documents into Mandarin, Cantonese, and
that's fantastic,
and a few different East Indian languages, because that's so common. At the same time, because those populations are that way, we have a lot of behavior analysts that are, come from those backgrounds, which is great as well.
Yep.
But also speaks to, I think, the piece, to your point about how everybody should be culturally aware and culturally competent and whatnot, regardless of their background. Because what often happens too, I think, and we've seen this I've seen this in companies I've worked in, is that sometimes these behavior analysts get pushed into the sort of compartment of only working with those families that come from their background. And that's not what they want, even necessarily. But they're pushed that way because of their language.
And I think that's, again, we see that also with clinicians who are highly skilled in behavior reduction or managing severe behavior, that becomes their entire caseload. And, when we think about burnout for any helping profession, but burnout in behavior analysis, it's often when you match supervision or supervisors with cases that are, if they've said, I don't want to work with this type of case, or this isn't filling my bucket, or can we at least spread it so I have a couple cases like this and a couple cases that do fill my bucket. I think it's important if, like you're saying, you've got clinicians who are only working with this population because they speak that same language. Their diversity is also lacking. Their ability to work in other diverse populations might not exist. So I think it's important to think about and ask those questions to those BCBAs.
Because on that, I'm wondering what your thoughts are on, and this may be too big of a topic for right now, but I don't know if this is what you'd call it, but sort of culturally responsive kind of OBM. So how do you sort of, and I suppose you can really apply a lot of what you've said today, but how do we sort of think about, being culturally responsive when in our hiring practices and in our internal training practices and in our internal expectations and those sorts of things? Have you thought about that or kind of come across that sort of area at all?
The only experience I have in that was my role at a large scale organization where we talked a lot about, in our hiring practices, removing the name, removing any background information, and truly reading resumes for the resume. Yes. So when I was a clinical director looking to hire other BCBAs, all identifying information for that individual was removed, except for the experience and training, so that we could select clinicians according to their experience in one. And then in two, during supervision. So, making sure that you're meeting with these, if you're someone overseeing numerous BCBAs, meeting with them frequently. And again, asking about their experience, talking about their experience, especially when it comes to culture. Have you taken courses? Have you read text? Should we host a journal club? Should we have these conversations? One of the things I know in my last practice that we talked about was it would have been fantastic to have kind of a round robin of conversation about culture. Right. Just let me share who I am and where I come from, because that might shape how if you encounter a family with similar experience. I was on a DEI committee, and I know there's a lot of theory on some companies shouldn't have committees, right? Committees means you have a problem. But it was a group that had a DEI committee. And a lot of the conversations we had were, how do we at large scale provide training on diversity? How do we ensure that, our clinicians have access to multiple different clients, not just this, like if you're scheduling your BCBAs in one region and one territory, you might be limiting their ability to work across different types of families. If you've got, and I worked in the Bay Area, so there were some region that I worked in where it was, the funding source was very different than another region. So I had some very families that were very much socioeconomically doing well financially. And then I had some families who were not. And that disparity is also cultural. And my ability and my interactions with those families were very much shaped by their experiences. So I think in an organization's practice, really thinking about, like you said, OBM, but then thinking about your clinicians and their experience and their territory and their background, having those conversations are important to making sure that we're aware from the top down.
Yeah. And recognizing my own bias as an interviewer, I know that there are questions that I'm not going to think to ask. So I wonder if there's sort of anything else in terms of sort of culturally responsive care that we haven't touched on that you want to sort of add to the conversation.
Gosh, that's a loaded question. I have so many recommendations I can make. I think that there is a lot to consider in this space. Yeah. I think that, we are learning and growing as a field. The last thing I'll add, and I say this often, is, if you're a listener, you probably have seen or heard of this YouTube video, but Pat Fryman has a video, "There's no such thing as a bad boy." Right. It's one that, I watch it and I cry every single time, depending on where I am in my career, in my work week, with my own stressors. But I cry out of joy in that truly the best way to approach culturally responsive care is to have that circumstantial view, that every individual and then every family, right, comes from a different circumstantial view. And the only way that we can serve them properly is to gather that information of their view, their experience, and who they are without making assumptions based on their last name, their first name, the color of their skin, what city and state they live in, what city and state they used to live in. I think the only way we can be truly culturally responsive is by gathering that information from the sources themselves, which are our clients and their families.
Awesome. Well, I think that's a good place to wrap things up. Nissa, thanks so much for coming on the podcast. I learned a lot today. I really appreciate it.
Thank you for having me. This was fun. It went quick.
Nice. There is a lack of diversity when it comes to educational material depicting Black children in the field of applied behavior analysis. Human Expressions gives Black and brown children realistic and detailed images of kids who look like them, modeling everyday skills that may be difficult for them to communicate or express. At Human Expressions, the benefits of representation for Black and brown kids in educational curricula are clear. Increased self-esteem, reducing stereotypes, and increased validation and support. To learn more, go to www.humanexpressions.org. That's human, HUEMAN, expressions.org. The third secret word is dissertation.